The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and it's a pleasure to be hosting the podcast, and thanks to everyone who is listening in. I told you last week that I just recently wrote a 4-part series on health plan economics, and in a couple of podcasts, we are trying to sort of take some of the material from that blog series and sort of bring it into the podcast. I noted that back on February 2nd and February 9th, I had two fairly lengthy podcasts regarding Medicare Advantage, a lot of economic implications discussed in those podcasts. So you could go back to the 2.2 and 2.9 podcasts to listen to Medicare Advantage economic implications. Last week on 5.10, I discussed the exchange marketplaces and how there was a rocky start to setting them up, but now we are on a much better fiscal path for them. And I also discussed what would happen if the enhanced premium subsidies somehow were to go away after 2025. This week, we are going to cover the Medicaid program and some of the financial and economic challenges that are in that program. And next week, we'll probably talk a little bit about general economic trends in all lines of business. So let's get to the podcast for this week on Medicaid, and we'll talk through that and some of the impacts of Medicaid redeterminations and the major disenrollments that are occurring. We will again take 2 breaks here, so we'll have a couple of ads coming up during the podcast. So let's give you a little bit about the Medicaid landscape. So just like Medicare, Medicaid tends to have both a traditional fee-for-service environment in each state, as well as managed care. So originally when the program started, and it's important to remember that this is a federal and state partnership program. The Centers for Medicare and Medicaid Services oversee Medicaid policy, but each state has its own state Medicaid agency to operate the program. They must follow certain federal rules, but they can put in other rules themselves as well. And originally, pretty much all of Medicaid was fee-for-service. Over the last several decades, managed care using private MCOs or HMOs or managed care entities have become very, very popular in states. While there is a rough 50-50 mix of the two systems in Medicare today between fee-for-service and Medicare Advantage, Medicaid tends to have a higher concentration of managed care. The Kaiser Family Foundation finds that roughly 3/4 of all Medicaid recipients are in some form of comprehensive managed care. 42 states, including the District of Columbia, contract with private managed care plans for some or all of their Medicaid populations. So the penetration of members in managed care in Medicaid is much greater than it is in Medicare Advantage currently. Why is this? Well, number one, while some states lag due to their rural nature, states concluded early on that the traditional systems were very costly and were of poor quality and really provided great risk to the state budget. In the case of Medicare, folks voluntarily enroll in managed care or Medicare Advantage, but in states, many populations are mandated to go into the managed care programs, and that suited states much better given the cost and the poor quality in the fee-for-service systems. So these states really turned to managed care companies to better the quality, but also to control costs. At first, most Medicaid recipients enrolled in managed care were mothers and children that were often associated with the Temporary Assistance for Needy Families Welfare Program. And that still is the bulk of the types of population in Medicaid today. Obviously, over time, more populations were added And most of them ended up in Medicaid managed care as well in most states. It is also the case now that many states are placing their so-called aged, blind, and disabled, or ABD populations, as well as the federal supplemental security income populations in managed care. That's not always the case, but that is an increasing trend in states out there. Many of these are on their way, these SSI and ABD populations, to Medicare primary coverage, and often after they obtain Medicare coverage are what are known as dual eligibles. They remain eligible for both Medicare and Medicaid because they qualify for disability or age and take on Medicare primary coverage, and they also are poor, so they get secondary Medicaid coverage. So these populations increasingly are going into Medicaid managed care as well. And in sort of the latest development in Medicaid managed care at the state level, states are contracting with managed care entities to control costs for chronic long-term care as well. Many states are asking a managed care entity to manage both the medical, and it could be either primary or secondary, as well as long-term care needs, all in one plan. As we discuss often in the podcast and in my blogs, nursing care, you have to remember, is limited to rehabilitation and short stays in the Medicare program. The Medicaid program is the program for chronic long-term care. Now, let's talk a little bit about payments. So payments to Medicaid managed care represents about 52% of expenditures for Medicaid. I told you earlier that 74% of all enrollees are in some form of comprehensive Medicaid managed care, but the expenditures only represent about 52%. Well, why is that? Well, again, despite having 74% of enrollees, the lower expenditures attached to Medicaid managed care is largely because much of the long-term care expenditures in the Medicaid program are still delivered within a fee-for-service program. And it's also the case that some of the most ill beneficiaries, like those ABD and SSI populations, in many states remain in fee-for-service as well. And there are other chronic populations that are in fee-for-service. So all of that means that, even though the number of enrollees are 74%, the actual expenditures are more like 52%. Now, that's an interesting contrast with Medicare, because opponents of managed care argue that Medicare Advantage plans receive well more than 50% of Medicare payments, despite being just above 50% of enrollees. They also argue that there is beneficial selection in MA, and therefore there are overpayments to MA plans because the amount of expenditures are north of the 50% of enrollees in Medicare Advantage. And so it's an interesting contrast where more enrollees in Medicaid, a lower percentage of expenditures, about 50% in Medicare Advantage, but a higher level of expenditures. You know me, I think there are two sides to this story when it comes to Medicare Advantage. I think there is some overpayment, but I also believe that some of that reimbursement is reasonable because managed care plans are documenting illnesses and risk in the program. So I just thought that was an interesting contrast to raise here as well. Let me cover a couple of other things on the Medicaid landscape. So first of all, the Centers for Medicare and Medicaid are really seeking to tightly integrate, as I alluded to, the Medicare and Medicaid populations so that these dual eligibles are managed in one plan, again, for all of their Medicare and Medicaid acute care medical needs and for long-term care needs. And there are a lot of changes going on in the Medicare world to really force this very tight integration. And over time, what will happen is Medicare Advantage plans will have to have sister company Medicaid plans that can serve both the Medicare and Medicaid needs and both the medical needs and the long-term care needs either in one plan or with tightly integrated sister plans, so to speak. So that's becoming an increasing policy of the Centers for Medicare and Medicaid Services, and we'll see that continue to roll out. And one last note, most states carve pharmacy, retail pharmacy, into managed care plans. But under new rules, the expenditures of managed care and fee-for-service are bundled together with all Medicaid drug spend, and on the brand side are collectively eligible by the state Medicaid agency for a mandatory federal rebate as well as supplemental state rebates. Most states believe that having the pharmacy integrated with medical care under Medicaid managed care makes the most sense, but there are a good number of states now that are carving the retail drug component out of managed care, and states are running it themselves with some PBM type vendors. But I believe that keeping pharmacy and medical care together actually makes the most sense. So let's talk a little bit now about the Medicaid managed care profile, since we just covered the landscape. Well, Kaiser Family Foundation, one of the best sources out there, notes that there are 287 Medicaid managed care entities delivering services throughout the United States. That was as of mid-2021. And again, as I noted, these are a mix of private for-profits, private nonprofits, as well as government plans. Large national managed care plans have many Medicaid managed care subsidiaries in individual states. As such, Kaiser Family Foundation finds that 5 publicly traded national companies account for about 50% of all managed care enrollment. Those firms are Centene, which is the biggest, United Health Group, Elevance Health, Molina, and Aetna, which is owned by CVS. So there's a big domination of Medicaid managed care by big national plans. But let's offer another contrast here as well. There is still a very healthy penetration of local plans and even provider-sponsored plans in Medicaid. They control about 50% of the lives, and the very largest managed care companies out there control about 50% of the lives in Medicaid. When it comes to Medicare Advantage, I told you in a recent blog and podcast that about 3/4 of all lives in Medicare Advantage are sort of controlled by 7 or so very large national healthcare plans, and only about 25% are controlled by other entities out there. So again, a bit of a contrast between Medicare and Medicaid. So let's next talk a little bit about what happened during the COVID pandemic to drive Medicaid enrollment, and then after, when regular enrollment rules returned. So when the COVID pandemic set in, Congress passed a temporary measure that allowed recipients who qualified for the program or who were already enrolled to remain on the Medicaid rolls until the pandemic emergency declaration ended. In essence, this suspended what we know as the redetermination of eligibility process in the program. Generally speaking, those redeterminations occur usually annually, and you have to prove that you're still eligible based on income or other factors. But in this case, the COVID bill sort of forestalled that and allowed people to remain in the program. As such, Medicaid enrollment surged. At its peak in April of 2023, Medicaid and the related children's health insurance program called CHIP enrolled 94.5 million people, 23.1 million during the COVID period. So a huge rise when regular eligibility rules were essentially forestalled. As of April 23, however, under a new bill, the public health emergency ended and redeterminations began again. So regular eligibility rules are now being applied. So since April 2023, these redeterminations have been processed for everybody in the program. For the most part, we're now, a year into it, and the vast majority of redeterminations have been processed. And that means that the number of enrollees dropped dramatically. So Medicaid and CHIP shed about 10.1 million members through January 2024. And because some redeterminations continue on, that number will grow a bit. So the rolls have really dropped by about 10.1 million members. What I would note, though, is that the actual impact on people is much greater, because that 10.1 million is a net number. There are new people qualifying for the program and more going off. So in general, the displacement of people from Medicaid was actually much greater. The displacement was somewhere over twice that number, over 20 million, approaching 21 million of enrollees lost eligibility permanently or for some period of time when redeterminations began again. So again, about over 20 million people were displaced because of the redeterminations coming back, and the net impact to the Medicaid and CHIP rolls was about 10 million lives, and again, that number will increase. Now, this obviously had huge impact on people's lives because some of them did find employer coverage or made their way to the exchanges, but others did not, and they just lost coverage. And so over time, we believe that the uninsured rate will grow by millions. But it also impacted plan revenue clearly because so many people came off the rolls that health plans, these managed care entities, had much less revenue. Almost all managed care entities have lost lives since April 2023. The Kaiser Health News and Kaiser Family Foundation found that Medicaid enrollment of the 5 big national companies had collective enrollment declines of about 10% from the end of March 2023 through the end of December 2023. Their enrollment dropped from 44.2 million people to 39.9 million. For example, Centene reported that its Medicaid enrollment fell 18.5% to 13.3 million from Q1 23 to Q1 24. United Healthcare's Medicaid enrollment fell 700,000 to about 7.7 million from March 23 to March 24. So a fairly major decrease among these top 5, roughly somewhere about, again, 50% of the 10 million lives lost in Medicaid overall, basically, hit these folks. So probably a little less in the case of the big 5. It appears it's probably more about 4 million, but the numbers make sense overall based on what I told you earlier. What I want to tell you next after we get back from the break is that the managed care plans actually found ways to work with states to end up making their revenue impact a lot less than it could have been. And that's because of some savvy lobbying and things like that. And we'll talk about that when we get back from the break, as well as what may happen in the future because of all of these lost lives for the managed care plans. We'll be back in a minute.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back from the first break. And we just ended giving you sort of a broad overview of health plans as well as some of the losses due to the recommencement of Medicaid redeterminations. we sort of ended with some of the big plan losses. And I made some allusion to the fact that there was some work, some lobbying work that essentially managed care plans did, probably driven by the big five or so, with the 50% of enrollment across the nation. So these publicly traded companies and some other outfits out there serving Medicaid members did a very good job of, first of all, setting expectations with investors when it was important, if they were publicly traded. Largely, these very large firms had very conservative calculations for what they anticipated their losses were going to be. Many of them hyped the potential growth of the exchange rolls if they offered that product too. As the losses started to come in 23 and into 24, these big plans with investors out there were able to report that they were doing better on the enrollment front, or at least meeting the expectations that they had set out. So they disclosed rather conservative estimates, and then they basically said they were doing better or meeting those expectations. So that is sort of a good sort of investor tool that they use to not spook investors in their plans. Now, obviously, healthcare stocks may have gone down for other reasons, but I think these very big publicly traded companies and some others tried to set expectations pretty well. Now, it's also interesting that many of the big plans continue to report year-over-year Medicaid revenue growth. Not all of them, but some of them did. And how is that possible? Well, notwithstanding everything that was going on, some of the big plans reported these good revenues from the program, and again, in some cases, year-over-year growth. KHN and KFF reported that United Healthcare, Centene, and Molina had Medicaid revenue increases ranging from 3% to 18% in 2023. For example, in Q1 2024, United's Medicaid revenue went to $20.5 billion from $18.8 billion in Q1 23. Molina's Medicaid revenue was almost $7.5 billion in Q1 2024, up from $6.3 billion in Q1 23. So if they were losing all of this enrollment, and we told you earlier that the estimate was that the collective Big Five grouping lost about 10% from the end of March 23 through the end of December 23, how could they be reporting, in some cases, not all, year-over-year growth in Medicaid? Well, frankly, again, the Medicaid managed care plans lobbied hard and made a good case to their Medicaid agencies that they merited interim increases during this displacement period, as well as healthier annual increases generally. With states very beholden to managed care to both control costs and run their programs, states have to listen. In my days as state budget director, I regularly met with the Health Plan Association that served Medicaid, given the service they carried. The plans use this sort of playbook here, and let me walk you through it. So number one, states do pay Medicaid managed care plans rather skimpily. Target margins in the Medicaid managed care world are well below other health plan lines of business, especially normally what occurs in Medicare Advantage as well as in commercial. I usually see margins targeted at about 2% in Medicaid managed care. And in tough times, the number is even less. In good years, again, MA and commercial lines, minus the exchanges perhaps, but that's improving as well, can achieve at least double the percentages that the Medicaid managed care folks get. So at least 4% margins in MA and commercial compared to 2% in Medicaid. The low rates are driven by very low provider rates in Medicaid, except to some degree in primary care as well as with hospitals, which have created sort of these unaccountable programs, and they get reimbursed reasonably well. But in general, margins are low, rates are low, and nobody really wants to buck that trend in Medicaid managed care. And while advocates, number two, may disagree, Medicaid managed care plans generally have usually done a good job of improving care and delivering for members, even with great risk and low revenue and low percentage margins. Again, advocates may disagree with my belief here, but one way that plans do this is using the power of their Medicare and commercial networks to augment Medicaid ones. If managed care did not have that power to broaden networks by leveraging other lines of business, access and quality and other things in Medicaid would be far, far worse. So I think it's really a legitimate feather in Medicaid managed care's cap for sure. So they have these skimpy margins generally, a lot of risk. They tend to do a good job of broadening networks. And another reason that states were willing to do this for Medicaid managed care plans, giving them interim rate increases and better annual ones, was because, again, during COVID, the federal government upped its reimbursement percentage in return for keeping Americans enrolled through the pandemic. In effect, states were rather flush with money. For each member enrolled in Medicaid and CHIP, states could charge the feds their normal matching rate and the temporary kicker that was put in place, which was pretty profitable for these states. While the feds pay a majority of Medicaid costs around the nation, this added kicker actually pushed the net cost greater to the feds up and to the states down. It is true that states had to pay a share of each additional member that was kept on the rolls, but it also received a big tranche of other federal assistance. So in general, states were flying pretty high with a lot of federal money, whether it was Medicaid or other federal aid that they could use to pay this bill. So plans also successfully argued that the lost membership was creating adverse selection. And again, what do I mean by this? The plan speculated that healthier individuals were disproportionately leaving, and the enrolled cohort that was left was sicker. I say speculated because in some cases there may not have been a lot of data, but I do not doubt this hypothesis. When Medicaid was first expanded, we saw adversity set in because sicker people who were uninsured sought out the expanded coverage. As time went on, that phenomenon settled out, and as rolls grew during COVID, the law of large numbers would have generally reduced risk. So when you take a huge number of enrollees away, the opposite could be true, or is likely true. The cohort got sicker. As well, many who lost coverage were not categorically eligible, like the SSI and other folks. And these categorical populations tend to have sicker profiles. So in summary, the plans had a great battle plan to get better rates out of state Medicaid agencies. They had very good relationships. The relative free cash during COVID helped, and the successful lobbying effort by plans related to the increased adverse selection and the fact that states rely on Medicaid managed care to deliver all made the possibility of increased revenue very real for these plans. And so this greater PMPM revenue that came with the incremental rate increases and better annual increases helped offset the revenue from lost enrollment. And voila, the Medicaid managed care plans tended to do better than was actually thought. So let's now get into, a little bit about, but what is in store moving forward for these plans? So things will get far more uncertain, in my view, for Medicaid managed care. Extraordinary federal dollars are going away. The COVID Medicaid reimbursement goes away as well. The positive shift in Medicaid share of costs away from state actually reverses. The shift now is back to states. This cost shift creates huge challenges for plans and state Medicaid agencies moving forward, as does a return of moderately aggressive inflation and utilization. But I don't see plans abandoning Medicaid because of it. Again, enrollment is still high. Plans have created a rather efficient engine, and government program companies like Medicaid for a number of reasons. Medicare and Medicaid are run similarly. Overall administrative costs can get spread over the two lines of business. And the federal government is also pushing, as I noted, for greater integration of Medicare and Medicaid. So plans need to be in both businesses to meet the challenge. So again, times are going to get tougher, rates are going to contract a bit, and Medicaid managed care will have to deal with that. But a whole bunch of forces tend to keep these folks in the Medicaid line of business. I would also note another positive trend that has emerged over the last several years between Medicaid and exchanges, and this also accrues to the benefit of the nation as a whole. But many of these Medicaid managed care plans, increasingly government program companies also like the exchanges, as the program fits into that government program framework that they could administer together and spread some of these overhead costs. This is in part due to the Biden administration's vigorous endorsement and support of the exchanges. The Robert Wood Johnson Foundation noted in a recently released analysis that the overlap between the exchange marketplace and Medicaid has continued to increase. In 2024, about 75% of counties have at least one managed care entity offering both marketplace exchange and Medicaid plans. The biggest Medicaid plans have the highest overlap footprint, and it is increasing each year. Centene, as an example, the biggest Medicaid and exchange provider, has an overlap of about 65% of the more than 2,100 counties it is in. Elevance Health has an overlap of about 40% of the almost 1,700 counties it is in. United has moved its overlap from 25% to 35%. So that's a positive outcome too. And it's very exciting because it meets a national goal of ensuring people have choices and continuity of care as they may move from one government program to another, for example, to Medicaid, to the exchange, or back again at some points in their lives. So with that, let's do this. We're going to take our one last break here, and we'll come back and talk about a little bit about the impact on providers with all these Medicaid disenrollments, as well as conclude about what is again in store for Medicaid managed care.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back. And we're just going to conclude the podcast now with a little bit of a reflection on the impact to the providers that provide many Medicaid services to enrollees out there, how they're being impacted, as well as just sort of give a conclusion and a sum up. So perhaps the biggest impact of the Medicaid disenrollments out there will be on providers. I've just told you about how very savvy Medicaid managed care providers got interim rate increases to sort of solve part of their revenue problem despite the lower enrollments. But it's really the Medicaid providers that will have the toughest time out there. During the COVID years, providers were able to rely on the fact that individuals were insured and various government programs could be billed, whether it was the exchanges or Medicaid or even Medicare in some cases. It was a steady flow of dollars and a known revenue source. Now, providers will need to turn to safety net funding again and grants to serve these once insured populations. These people are still coming through the doors, and plans can no longer provide coverage to these individuals because they've been disenrolled, but the providers are sitting there with these people at their doors, and they are going to have to really undertake a couple of things. They're going to have to build safety net programs, and I would note that these are at much lower levels today than they were, primarily because of the Affordable Care Act was meant to provide upfront coverage, and those safety net programs were largely cut at both the federal and the state levels. And to the degree that a person may have been disenrolled for procedural reasons, many of these providers are going to have to also make investments in administrative areas to help these individuals become eligible again if they can get them back into Medicaid or into exchange or some other type of program. So there's really sort of two providers out here we think about. Number one, we think about the hospitals. Fitch Ratings, a prominent ratings agency, says that nonprofit hospitals will see revenue impacts, with safety net hospitals seeing the most impact. In addition, hospitals will need to resort to hiring, again, administrative staff to see if the now uninsured qualify for coverage. So sort of a double whammy there. A new study also reports on the major impact to patients at so-called community health centers. These are sort of oftentimes federally qualified health centers. They are in census tracts that serve low-income individuals and those with very, high social determinant impacted cases. And these community health centers are actually reporting a disproportionate amount of their enrollees disenrolled from Medicaid. And this has huge impacts on access to care and even means interruption of care for many of these people that are being treated at community health centers. In many ways, these FQHCs or community health centers serve the poorest of the poor. And if they are seeing disproportionate disenrollments, again, what is a community health center to do? The CHCs did win increased funding in the 2024 budget compromise that just passed at the federal level, but the loss of significant Medicaid revenue impacts their ability to deliver care and provide for the needs of both the insured and the uninsured. I would also note that remaining independent practices out there that are more primary care or even specialty related in these underserved areas will also be impacted. So I think we are in for a major problem in terms of providers serving these individuals with the Medicaid disenrollments. So what did we really learn from what we discussed today? Well, number one, Medicaid managed care plans can be rather savvy. They have found ways to serve the population with fairly low reimbursement. While their fulfilled pleas for more reimbursement during the redetermination process is not without its risk, it is less risky than what many MA plans with some corporate owners did by augmenting benefits tremendously, even though they knew they had low star scores coming, and the huge rate hikes that they saw in prior years were not going to happen. So they probably planned worse in MA than what occurred in Medicaid. The state rate environment will tighten with less free money and a shift of costs back to states. Plans will need to deal with this and push for holding the advances they've made. If President Biden is reelected, the overall Medicaid policy will be one of continued expansion, which generally favors the plans in terms of financial generosity at the federal and state levels. If former President Trump wins, Medicaid policy will likely be under attack, much as exchange policy will be, which makes opportunities for more revenue less certain. But it is also true, regardless of who is president, that monies in the Medicaid arena and in general will tend to be tighter given the federal budget deficit and new rules out there. Thus, overall expansion of populations and hefty rate increases are less likely moving forward, And again, that's something that Medicaid managed care plans are going to have to deal with. Plans, too, have to ready for a whole range of new mandates aimed at greater accountability and pushing quality. This new rule was just passed for calendar year 2025, and that is going to be more administrative costs for these plans as well. The Kaiser Family Foundation also notes that Medicaid managed care prior authorization denials are much greater than what has occurred in Medicare Advantage, 12.5% versus about 5.7%. And since CMS passed some rules related to prior auth and MA that I think are terrible, you could expect to see potentially something occurring in Medicaid as well over time. I would also note that state regulators are also getting far tougher on Medicaid plans because the feds are holding states more accountable as well. The move is a trend that we are seeing in every line of business. So these Medicaid managed care plans will need to argue they need more dollars, not only to solidify their rate position, but also to deliver on a whole bunch of mandates that are being forced upon them. So that's basically the health plan economic status of Medicaid managed care. We hope you enjoyed this podcast, and we'll see you on the next Healthcare Labyrinth podcast. Take care.
Thanks for joining Marc and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.